apologies for this little delay, and thank you so much for inviting me to talk about study designs in clinical research. I come from basic science background, so the majority of studies that I am involved in are preclinical studies or evaluations of risk factors that lead to cancer development. But I will be talking primarily about just general principles and key factors in conducting cross-sectional and case-control studies. And I will give you maybe just one example of application of a case-control study from our research. So you may have heard about different types of study designs. So there are cross-sectional studies, prospective and retrospective cohorts, case-control studies, and randomized controlled trial, which you will be hearing about in this workshop. And as you can see, these different study designs, they cover different periods of time and allow you to answer different questions about the relationship between different risk factors and disease risks, as well as the impact of treatments on disease outcomes. So it goes from the past into the future. And we are focusing at this time on cross-sectional study, which is like a snapshot in one period of time, as well as case-control study, which allows you to actually look back and to identify potential risk factors. So there are some differences in approaches in how participants are selected for these studies. And this, again, allows you to answer very different questions. In cross-sectional studies, participants are typically selected based on specific inclusion and exclusion criteria that are set for this particular study. And then you can observe potentially differences in disease risk, while for case-control studies, participants are selected based on the outcome status. So there is usually a specific disease status, and then matching controls are selected. We'll start with cross-sectional studies. So cross-sectional study designs are typically used for population-based surveys and also to assess the prevalence of diseases in clinic-based samples. And these studies can usually be conducted relatively faster than, for example, longitudinal cohorts. And these studies are also quite inexpensive compared to other clinical trials. For example, if you think about cohort studies, there are some similarities because cross-sectional studies conceptually begin with a population base, but unlike cohort studies, in cross-sectional studies, we do not follow individuals over time. And instead, we only look at the prevalence of disease or maybe prevalence of exposures, like in studies that I am conducting. You're looking at it at one moment in time. And for that reason, as I mentioned earlier, these studies are like a snapshot of the proportion of individuals in the whole population that are, for example, having disease or not having disease at one point in time. In some of these cross-sectional studies, other outcomes besides diseases may be also studied. And Cross-sectional studies also different from cohort studies in terms of the populations that are being studied. For example, in cohorts, you begin by selecting a population of people who are at risk for specific disease or for specific health outcome. In cross-sectional studies, you begin by selecting a sample of population, just a general population, and then you obtain data to classify all these individuals from your study as either having or not having the health outcome. And once the participants have been selected for the study, you usually look at these outcomes, and there is no prospective or retrospective follow-up in such studies. Now, usually, as I mentioned, in cross-sectional studies, you are focused on prevalence. And prevalence refers to the proportion of people in the population who have a particular disease or some kind of attribute at a given time, regardless of when they first developed this disease. It is important to distinguish prevalence from incidence. Incidence refers to the number of new cases that develop in a given period of time. But in cross-sectional studies, researchers typically describe the distribution of variables in population. So they may assess the prevalence of a disease or association of an exposure to a certain outcome in a population. I am showing a simple hypothetical example of a cross-sectional study that is illustrated in the blue box, where two different submeasures can be calculated. The prevalence of coronary heart disease, or CHD, among exposed people, for example, people who are not active, and the prevalence of coronary heart disease among unexposed people. So these are people who would be active. So you can see that prevalence for those who are not active, prevalence of coronary heart disease would be 50 when disease is present, divided by 250, which is total number. So you get a 20% prevalence of disease among people who are not physically exercising. And in the same study, you would have a cohort, people who are actually active. And in that case, you divide 50, number 50, where disease is present, by the total number of 750, and you get prevalence of a disease at 6.7%. So this is just a simple example, hypothetical example, how prevalence is assessed. So when would you conduct a cross-sectional study? You would use cross-sectional study design when, for example, the purpose of the study is descriptive. Often in the form of survey. In such study, usually there is no hypothesis as such, but the aim is just to describe a population or a subgroup within the population with respect to a certain outcome and maybe a set of risk factors. You can also use cross-sectional studies when the purpose of the study is to find the prevalence of the outcome of interest for a population or subgroups at a given time point. So you can do it for descriptive purposes, or you can do it to establish prevalence, as I talked about it in the previous couple of slides. There are also other variations. For example, cross-sectional studies are sometimes carried out to investigate associations between risk factors and the outcome of interest. These studies are limited, however, by the fact that they are carried out at one time point. So there is no indication of the sequence of events. So you can't tell whether exposure occurred before, after, or during the onset of the disease outcome. So in this case, it's pretty much impossible to infer causality. That being said, cross-sectional studies still indicate some associations that may exist between exposure and disease, and for that reason, they can be useful in generating hypotheses that then can be tested in future studies. And another variation is repeated cross-sectional studies. So these studies give you a kind of pseudo-longitudinal outcome, where the individuals included in the study are either chosen from the same sampling frame or from a different one. One example, I will have other examples, but just briefly, there is this study of community dentistry survey that was conducted by the British in Britain. And so they looked at 5-year-old children who were examined annually and looked at the prevalence of caries. And this prevalence for this age group was monitored over time. So each time it was a cross-sectional study, but each time it was done in a different population of 5-year-olds. So that gives you kind of important information that can, for example, inform public health policy planning or developing some intervention strategies. I hope that wasn't too confusing. Okay, so some examples of cross-sectional studies. For example, Thomas and co-authors, they conducted a descriptive cross-sectional survey on the prevalence of dysfunctional breathing in patients treated for asthma in primary care. And they had 4,381 patients aged 17 to 65 years old. And they had diagnosis of asthma from medical records that was available from medical records. So there was, as you can see, some reduction in numbers. Usually you have this, you lose participants. 307 met the criteria and completed questionnaires. Only 227 questionnaires were actually returned. So 307 were asked to complete questionnaires and only 227 returned. But then out of those, only 219 were suitable for analysis. And the main outcome in this study was a score that was calculated based on the answers to the questionnaire. And in this kind of study, they found that about 1/3 of women and 1/5 of men had scores suggestive of dysfunctional breathing. So this is kind of an example of simple prevalence assessment study in a cross-sectional study design. Another example is an analytical cross-sectional study. So this is where you investigate association between exposure and some risk factor. So in this case, it was a study of the association between passive smoking and respiratory symptoms. and it was in European Community Respiratory Health Survey. And this analysis included data from almost 8,000 adults who never smoked. And that was from 36 countries. So you can imagine it's really, really large cross-sectional study. And they collected information through interviews and spirometry and other data. And this data was retrieved from this big study, and they conducted regression analysis to look at the association between passive smoking. And in that case, passive smoking was assessed as prevalence of exposure to cigarette smoke at the workplace. And as a result of this study, looking at that association of reported prevalence of exposure to smoking at workplace and all the other factors, they found significant association with different respiratory symptoms in this population. So, and another, again, example of application of cross-sectional study design is this study of trends of COPD prevalence in Spain. In this case, they did repeated cross-sectional survey. So I gave you 3 different examples of different types of cross-sectional studies. And this is the one that I mentioned earlier, where repeated measurements give you kind of a pseudo-longitudinal study. So in this case, they used 2 very large studies. One was conducted in 1997, and the other study was conducted in 2007. So investigators in this analysis compared participants from 2 cohorts. And by doing this analysis, they were able to detect changes in the prevalence of COPD, which is chronic obstructive pulmonary disease, in this population. So that was a very interesting finding. They also found some differences in the severity of COPD, the distribution of severity, where not only prevalence dropped, but also the relative contribution of severe COPD cases also was reduced in 2007 compared to 1997. So I hope these are kind of clear examples of some of the applications of cross-sectional studies. Now, a few comments on important factors if you are planning cross-sectional studies. Planning the sampling strategy is really important component. And this is important because of the heterogeneity of the population. So it's really important that you have a really representative sample of population that you are involving in your study. Usually the sample frame used to select your participants, as well as response rate, determine how well results can be generalized to the population as a whole. So there are 2 major categories of sampling methods. One is probability sampling methods, in which samples are chosen by using a method based on the theory of probability. And there are different types of these sampling methods. Some examples, some commonly used are simple random sampling or systematic sampling, stratified or cluster sampling. And the second category is non-probability sampling methods. And in this case, samples are selected based pretty much on subjective judgment. In general, probability sampling methods are preferred over non-probability ones because probability sampling is considered to be more accurate and more rigorous. However, if you think about applied clinical research, there are some circumstances in which it is not feasible or not practical to perform random sampling. And in this situation, you would apply non-probability sampling. Again, there are a few examples, such as convenience sampling or quota sampling or snowball sampling. So these are some of the common examples of non-probability. I would suggest that clinical investigators who want to conduct these studies definitely consult a statistician when designing a sampling strategy. I always work with statisticians. I believe in expertise. So all current research is highly multidisciplinary, and you can potentially learn some of the statistics, but it is best to work with a statistician because if sampling approach is not adequate, then you can conduct a very expensive study, spend a lot of time and resources, and then not really get adequate and strong answer to the question that you actually had at the beginning when you planned this study. Okay, so again, related to statistics, and again, I'm not a statistician, but these are just some general guidance that sample size determination, again, is an important step. When you design a cross-sectional study, sample size calculations are different for a descriptive cross-sectional survey and an analytical cross-sectional study. So there are some distinct considerations that should be taken. When conducting a descriptive cross-sectional survey, the goal usually is to estimate prevalence of a particular outcome, as we already discussed. So in this case, investigators usually need to provide the assumed values of the prevalence rate, provide the desired margin of error, and also the significance level. So this is what we typically do. We assess this based on previous data, based on some published research or research conducted by us, and provided to statisticians to help us with sample calculation. Now, just a note that sample size in a descriptive study does not depend on statistical power because this concept only applies to statistical comparisons. Some potential problems for a cross-sectional study to be aware of. So I already talked about that results of these studies need to be representative of the population as a whole, and but also for these results to be representative of the population as a whole, not only you need to think about how sample is selected, but it is also important that responders are representative. And that is because non-response is a common problem in wide-scale surveys. So there could be a case that your sample was fairly representative, but then you have only certain type of people who actually responded to your survey or ended up participating in the study. So in the end, because it's certain type of people with certain characteristics, then your results may not be generalizable to the whole population. So to minimize non-responsiveness, you can, think about prompting, such as telephone calling or sending mail, reminding multiple times about the survey, about the participation, and so on. So the level of non-response is one concern, but the other concern is also biased response. It's kind of related to the first one, but a little different. And that is when a person is more likely to respond when they have a particular characteristic. And the bias will occur when this characteristic in question is in some way related to the probability of having the outcome. I'll just give you an example. For example, rate of a survey conducted by door-to-door interview looking for a particular disease. So if you go door-to-door and conduct this survey, it might be highest, and I'm thinking about, of course, studies conducted in certain countries. So what I'm describing may not necessarily be applicable to all different locations. But in some countries, if you go door to door, so you are more likely to get responses from elderly and unemployed people, because these groups are more likely to be in their home during the day. And these two groups are also more likely to experience higher levels of disease. So then you would get biased results. Another example of selection bias, for example, if you have a cross-sectional survey of asthma in an occupational group of animal handlers, so you would underestimate risk if the development of respiratory symptoms led people to seek alternative employment, and for that reason, they would be excluded from the study. Lastly, another type of bias is information bias. And it usually happens when key study variables are measured or collected or interpreted inaccurately. And one good example is recall bias. This is when people may complete a survey about certain exposures, but their memory is not quite accurate. Now, this is just a summary of advantages. Maybe it sounds like I mostly focused on disadvantages, but there are a lot of advantages in conducting cross-sectional study if the study design fits your purposes. It's always important to be mindful, what is that hypothesis? What is that question that you need to ask? And then sometimes cross-sectional study could be a really good fit. So advantages are that they are relatively inexpensive. They take up little time to conduct because it's just a snapshot in time, or you're even working with existing data. You can estimate prevalence of outcome of interest because sample is usually taken from the whole population. You can assess many outcomes and risk factors at the same time. These studies are useful for public health planning, for example, or for understanding risk factors for disease. These studies are also helpful for generation of hypotheses. So when you can test detect some relationship and then use a different study design to investigate this in more detail. And there is no loss to follow-up, which usually happens if you have longitudinal cohorts. So there are some benefits compared to other study types. And there are, of course, disadvantages. As I mentioned earlier, it is difficult to make causal inference with cross-sectional studies. It is only a snapshot, so it's one moment in time, and the situation may, provide different results if you choose different time frame. So there could be some environmental influences or other influences. And lastly, prevalence incidence bias. It's also called Nyman bias. And that is especially relevant in case of longer lasting diseases. So any risk factor that results in death will be underrepresented among those with the disease. So it's also a case of survival bias. Now we'll take a look for the remaining time at some aspects of case control studies. So again, just to remind, these are studies that allow you to look back pretty much at potential risk factors that led to the development of disease. And in this case, you start with looking at selecting participants based on the outcome status of disease of interest. So one of the important benefits of conducting case control studies is that they allow to overcome the drawbacks of longitudinal approach when you are trying to investigate the causes of disease that may have low incidence or maybe takes a long time to develop. So in case control study, patients who have already developed a disease are identified, and then you can look at their past exposures to suspected risk factors, and then you compare that to controls or references who do not have the disease. So this is where the case control study term comes from. And this allows you to estimate odds ratios for disease or for disease risk. So in case control studies, you need to make allowance for potential confounding factors. And you can do it by measuring them and making appropriate adjustments during the statistical analysis. To make this analysis or adjustment more efficient, you may want to consider matching cases and controls for different confounders. For example, for exposure or individual characteristics, for example, by age and gender and other factors. Or you can do it also individually or in groups. For example, you can choose a control group that has overall age and gender distribution that is similar to that of the cases. There is a difference between cohort study and case control study in that matching in case control studies does not on its own eliminate confounding. So you still need to do statistical adjustments. Now, how do you select cases? The starting point of most case control studies is identification of cases. first of all, you need a clear definition of the case, clear definition of the disease state. So what is it that it could be not just general disease, but very specific stage, for example, like in the case of cancer. And you may need to have very specific criteria at how the case was diagnosed and what are your very specific inclusion or selection criteria for that. So this is really important. You also, again, similar to cross-sectional study, you need to take care in how you select cases. So there is no bias in how they are selected. Again, just general hypothetical example. If you have a study of benign prostatic hypertrophy, so that might be misleading if cases were identified from hospital admissions, and admission to hospital was influenced not only by the presence and severity of disease, but also by other variables, such as social class, for example. So you may get cases that are well defined, but there is bias in who ended up being admitted to the clinic. So you don't really get representative sample of cases. Prevalence is influenced not only by the risk of developing disease, but also by factors that determine the duration of illness. So that, again, can be relevant to selection bias. And in addition, if disease has been present for a long period of time, then exposure to risk factors that happen before the disease development may be harder to ascertain, especially if this assessment depends on people's memories, like in just personal recall. So the duration is important for many different reasons. Key requirements or thoughts on selection of controls. So we talked about cases. It's usually not too difficult to obtain a suitable source of cases, but selecting controls tends to be more problematic. Ideally, controls would satisfy two requirements. Within the constraints of matching criteria, if you have matching criteria, you want their exposure to risk factors and to confounders be representative of the population that is at risk for becoming cases. So what I mean by that is that people who do not have the disease under investigation, but who would be included in the study as cases if they had. So their exposures should be similar. Also, exposures of controls should be measurable with similar accuracy of those of cases. And often it's just impossible to satisfy both of these aims. Two common sources of controls are the general population. So in this case, exposures are likely to be representative, but assessment of exposure may not be as accurate as for cases. And then sometimes you can use patients with other diseases as controls. But in this case, exposures may be unrepresentative. So, for example, if you're interested in individuals, your cases are lung cancer patients, and you might, use someone with COPD as controls because patients are coming to the clinic or neighboring clinic for respiratory disease that is not cancer. So one way to address this is to have two sets of controls with different possible sources of bias, and then you can kind of account for these different biases. So incorporate two controls with different biases. And another selection of controls, another point is that you want to have either equal number of controls per each case, or occasionally, as for example, for some rare diseases where sample size is very small for your cases, you may want to consider having more than one control per each case. In this case, matching can become a little bit problematic because you need a large pool of controls in order to match 3 controls for each case disease state. Okay, I think I probably need to move a little faster because my time is running out. So in terms of ascertaining exposure from personal recall, that is one of the methods of ascertaining exposure, but validity will depend in part on the subject matter. So some things are easier to recall than other. You can get exposures from historical records, from some established records. For example, if you look at the study of the relation between some disease or some infection and then disease development, you can look at medical histories and see actual track record of infections as a risk factor. So, and another approach is to actually look at biological markers of exposure. So this is type of research that we are doing, for example. This is useful when biomarkers are not altered by the actual disease state. So if you use inflammatory markers, for example, they may be affected by the presence of disease and would not be helpful. Some potential pitfalls. Care should be taken to avoid confounding, which arises when an exposure and an outcome are both strongly associated with some kind of third variable. So you want to make sure that controls are subject who might have been cases in the study, but are selected independent of exposure. And cases and controls also shouldn't be overmatched. So these are just some considerations. Now, very quickly, I wanted to give you an example of case-controlled study from our research. We are particularly interested in tobacco-specific nitrosamines and their role in cancer development in tobacco users. And these are very potent carcinogens. These are just some pictures of cancers caused by a compound called NNK that is present in tobacco. And this is lung tumors caused in laboratory animals by NNK. And NNN causes esophageal tumors and oral tumors in laboratory animals. Interestingly, NNN never causes lung tumors, and NNK never causes esophageal tumors in laboratory animals. So we didn't have enough data in humans till we conducted our biomarker study. So we conducted this study by retrieving data, not data, but samples and data from a Shanghai Prospective Cohort Study, which had over 18,000 men that were enrolled between 1986 and 1989, and then followed over decades. And this, we had information on the use of tobacco and alcohol in diet and medical history, but also had biological samples available from these participants. So what we did, we retrieved urine, and we wanted to see how biomarkers of exposure to these tobacco-specific nitrosamines, NNN and NNK, may be related to lung cancer risk and esophageal cancer risk in this Shanghai Cohort Study. In lung cancer, we had 93 cases, and we matched 1-to-1 to controls, and we measured urinary biomarkers of both carcinogens. In second study, we had only 77 esophageal cancer cases, and this is fairly small number, so it was important to us to match 3-to-1. So we had 3 controls per each case. And we conducted this in a blind manner. So it was very important that we didn't know, when we were analyzing samples, we didn't know who was case and who was control. And when we looked at the data, I will skip this because we are short on time, but this is pretty much chart summarizes what was in previous tables. We saw that higher levels of biomarkers were associated with higher risk for developing lung cancer for NNK, and this is the chemical that causes lung cancer in laboratory animals as well. But we didn't see this association for esophageal cancer. And for exposure to NNN, we saw very strong association with esophageal cancer, but not lung cancer. So this is an example where you can do this type of studies and actually provide important missing piece of information. Like in this case, we found remarkable coherence between animal studies and human studies. So pretty much humans are at the same risk for mechanism of action of these carcinogens. And just a little pitch for research that we are conducting now, it's a follow-up using similar biomarkers. We have a grant where we are looking at similar cross-sectional associations, but also case control study that we are conducting in Mumbai in collaboration with Dr. Gota, and looking at the relationship between exposure to these carcinogens and risk for head and neck cancer in smokeless tobacco users. So very quick, a summary of advantages of case control studies. They are good for studying rare conditions or diseases. They take less time than cohort studies, longitudinal observations, and they can also allow you to study multiple risk factors and can allow to establish an association with risk factors. Some disadvantages are that you may have problems with data quality, especially if you rely on memory of participants in the study. They are not good for evaluating diagnostic tests because it's already clear that the cases have the condition and the controls do not. And it also can be difficult to find a suitable control group, as I talked at length. So thank you.